You ready, Jack? A very good morning to you. Thanks for joining us for our virtual conference on procurement through the NHS, which will be full of useful content and innovation. Welcome to those joining us for the first time, and hello to our regulars in the audience. The National Health Executive is always keen to deliver content which inspires innovation on the platform long after the event has finished. So to access the on-demand content, please visit events.nationalhealthexecutive.com/on-demand. That always makes me smile because it's not very catchy. Today will be packed with opportunities to network and acquire industry knowledge and best practices from other NHS professionals. So I hope you're looking forward to what we've got in store. Before we begin, I'd like to thank our industry leaders and experts who have taken the time out to join us to share their high quality insights. It really is so much appreciated. Due to the standard of content that's going to be shared on our NHE 365 platform, it is worth pointing out that all of the content is CPD certified. So for every hour of content you watch, you'll earn 1 CPD point, and your CPD certificate will be sent to you in the next day or so. Please also note that our networking opportunities can be accessed via the speed networking function. I encourage you to collaborate with your colleagues as another valuable source of learning. This all plays a part in the community we're growing, a community built by you, for you and your peers and colleagues to share in the knowledge and connections. Also on the NHE 365 platform, you can access a wealth of resources in our on-demand content section, as well as the digital marketplace, where our partners provide information for you and your teams to digest at your leisure. Finally, feel free to share your thoughts and experiences today across social media using the hashtag NHE365. This NHS procurement event is designed to shed light on innovation and advancements which are reshaping the delivery of healthcare services, offering a platform for healthcare professionals and those with an interest in procurement to improve healthcare, to come together, exchange ideas, and explore the opportunities we have. So let's get started. Well, so our first panel, if we just got up slightly there, Jack, our first panel is about procurement reform. The rules to procuring services and products for the NHS are, as many of you know, complex. In this panel, we're aiming to understand what the latest reforms aim to achieve and how they will affect each part of the procurement process for NHS buyers and suppliers. The Healthcare Act 2022 promised to have a major effect on NHS procurement, with a shift in priorities, procuring in the best interest of patients and with less emphasis on competitive tendering. I really enjoy it when our discussions are a conversation with you, our audience, involved. So for the panel discussions, please do feel free to use the Q&A function on the right-hand side of your screens. It also helps if you can put who your question is for. So let's welcome our first guests. I'm delighted to say we have with us Edward Jones, Senior Policy Advisor, NHS Confederation, Brian Mangan, Value-Based Project Lead, NHS Supply Chain, and Pavanjit Devsi, Director of Procurement and Contracts for Barnet, Enfield and Haringey Mental Health NHS Foundation Trust. So glasses on and you're all there, which is always a good sign on a virtual conference. Welcome to you all. Let's kick off with you, Edward, if we may, just explaining for us how the rules for procurement of healthcare services are changing.
Thanks, Helen. So I think the first thing to probably well known by now, what we're trying to set out to do with the creation of integrated care systems is really enabling the local areas to deliver a shift towards a leftward shift, as we call it, towards prevention through enabling collaboration between local partners. So that's really at the nub of the wider set of reforms. And I think if you've got to look at the reforms to procurement of healthcare services through that lens. So we've got we're expecting in the coming months to see regulations laid before Parliament for a new provider selection regime, enabling local systems to to take decisions without always requiring the competitive tendering process, which is very much designed to help enable that longer term goal. Although I think at the same time, perhaps through chance really more than design, we've got this wider context of reforms going on to wider public sector procurement regime which we've seen through the procurement bill, which has been going through Parliament. That will affect all procurement of non-health services, so goods, things like social care services. So it's going to be a lot of change, I think, for the system to adapt to all short space of time.
Gosh, there's certainly a lot going on and a lot to talk about. Brian, following on from that, I mean, your thoughts on the latest reforms and how they'll affect the procurement process for both NHS buyers and suppliers.
I think really the work that I've been doing on value-based procurement, looking at the reforms, and being quite sad. I've got a presentation to do next week, so I've been going through it. I think really the VBP particularly really speaks to the new reforms, because what you've got in there, it's very much around, it's got things around sort of the public good and value for money. And it's very much moving us away from not just looking at the price of products, but really kind of the wider impact. And I think I think probably it leans towards the stuff that Ed was talking about around ICSs. Because typically what we do in a local hospital is you're looking at the price of the product, you're looking at what it means for you, but not necessarily taking into account what it means for the whole health economy. So for me, I think that the reforms are great in terms of being able to promote VBP. And then you've got the other aspect of it where what it's promoting is it's promoting dialogue with suppliers. A lot of it's saying it's about pre-market engagement. So I think it very much gives us the opportunity to talk to industry and say, these are the challenges we face. Have you got the capability and the capacity to deliver it? And I think that will really sort of generate more effective outcomes from the procurements that we actually do across the NHS.
Pav, just your thoughts on that before I ask you a more specific question, but your thoughts on our opening there and whether you're embracing the reforms as much as it sounds like Edward and Brian are.
Yeah. And accurately kind of summarise the two and what's affecting us. I think for me, there's probably, it's going to be really interesting because the amount of, I think, capacity, but also capability, and how that will. I think one of the specific things, and colleagues would have probably seen and heard of around contract management and contract KPIs and the reporting requirements that are going to come out in the new procurement regulations. That's something that we currently, so yeah, it's going to add a whole other layer, I think, to our teams that we haven't had before. And I think just to Brian's point, I think about how it's around value now, looking at the entire patient pathway. Some of the awards structuring it under the provider selection regime shows us that's the way it's going. But as always with these things, I think until we actually start implementing them and we actually start seeing how it works in practice, we don't know what that's actually going to mean for us. But yeah, it seems positive at this point.
That's good. And Pav, how can we work across care settings with other procurement colleagues to make sure that we're getting the best outcomes for service users?
Yeah. So ICSs and closer working within healthcare specifically, it's been promoted by NHSE through the central commercial function. I think that's really pushed collaborative working and how we do things together. An example, I think, is previously collaboratively, if we're working together, the acute organisations would procure high value medical equipment, and that would work for them. But specifically within our ICSs, we're looking at things like continence services and products. So the discussions that we're having are what is the patient pathway, how are continence products being procured for patients in the community, but then also how can we make sure that if they go into an acute setting, it's the same product. So yeah, there's lots of initiatives, I think, that are coming out around that now through the structure of the ICS.
Edward, what benefits do you feel that these changes in rules will offer both the NHS, but also, we always say, don't we, patients are at the heart of everything we do. How will they also affect patients?
So I think it's slightly different for each of the new regimes. So let's take the provider selection regime firstly. I mean, part of the design is a recognition that within each area there are.
Oh, just lost your sound there, Edward. Let's just see if we can get your sound back. Oh, I think Edward might have frozen there. Let's just give it a second, see if we can get him back. And if not, maybe Brian, you can pick up.
Always going to be the best place.
Edward, sorry, you
you
really
hear me now?
froze there. Do you mind just starting that again? Because we missed most of your answer there.
Yeah, not to worry. Sorry, the internet's been a bit temperamental today.
That's okay. If
so
it gets really temperamental, you can take your video off.
Okay.
We'd rather have your voice if we get more problems.
So I think the benefits are slightly different for each of the new regimes coming in. So if we take the provider selection regime, and again, this is only affecting the procurement of healthcare services, we know that there are some providers within each area who are uniquely placed to deliver certain services. At the moment, we have to go through a competitive tender for that, when really there's only one bidder who's best placed to do it. I think what the new regime will be able to do is allow commissioners to roll over contracts or to award the contract to the best placed provider. There's a lot of transparency requirements around that, but what that will mean is we're able to cut out some of the bureaucratic costs to that process. So there's more resources for the release to reinvest in patient care. And it also allows us to take a more coordinated approach to procurement of services to enable the integration of care pathways. And I think a shift from viewing particular services in a transactional manner, we need to go and do this operation here or this procedure there, but really commissioning, and I know that some systems were already looking at this, commissioning by pathway, care pathway, which should hopefully mean a smoother pathway of care and a better experience for patients. I know that on the where the procurement bill was, procurement act will be, is coming in. I think that the hope around here is again to streamline the process, make it more accessible for different providers, particularly small providers, to be able to access that market. So we should benefit from increased competition, increased efficiency in the supply of goods that are coming up. So I think overall, hopefully, more efficient and integrated care with better access to the latest technologies for patients.
Which, of course, then all has the knock-on effect of benefiting the patient long term, which is great. Brian, just thinking about the same thing for you, really, the benefits that you're seeing. Do you agree with what Edward said there, and are there more things that that you highlighted?
Yeah, very much agree with what Ed was saying just then. I think you mentioned about pathways. The work that we've done on value-based procurement in NHS supply chain, we've done a number of pilots. I say by taking the principles of the reform around sort of value for money and the wider benefits to the health system. We've had a couple of examples where we paid more for a product, but it's meant that it's reduced the time. It's it enabled the procedure to be done minimally invasive. So instead of being under the knife for an hour and a half and being in hospital for 3 days, people have had a 20-minute procedure and sent home the same day, which obviously then from a patient's experience perspective and potentially a patient's outcome benefits is, it's better for everybody. So I think very much looking at pathways is bringing the patient in to the outcome from the procurement process and what's actually being achieved. So I think that that really is a real benefit of the reforms. I think it's going to focus people's attention now on not just about short-term price, because at the end of the day, there's lots of procurers who will be on the call. We've all aggregated and standardised and looked at the price of products. So I think there's only so far you can go. There might be some fat in some areas. I think looking at pathways and really using the reforms as being a tool to help procurement make a wider contribution to the NHS. And I think that, for me, that's what I'm passionate about. It's about using the levers that the procurement professionals can actually bring to contribute to efficiency, my patient care as well.
You've been leading the value-based procurement project in NHS supply chain, and I know that I can see from the way you're speaking, you see many opportunities for adopting a value-based approach. I really enjoyed the example you gave there. Do you have a couple of other examples? Because it's those examples, I think, Brian, that really bring what you're doing to life, certainly for me, and I'm sure for people in our audience too.
Yeah, I mean, there's lots. If you go onto the NHS supply chain website, programs of EBP, there's a number of case studies that we've got on there, and they range from something. Mentioned about the inpatient today case. There's one that's on about remote monitoring as well. So it's about looking at bringing remote monitoring in, which stops people coming back into the hospital. Environment is quite topical at the moment. So it's, it saves journeys, better for the environment. You've got other things whereby there's another solution around looking to reduce catheter-related infections. And obviously then if you can bring technologies in that have a direct impact on reducing infections, it's far better for the patient, obviously. The patient gets an infection and they can be in hospital for 10 days just trying to sort out. So you've got all the, the mental strain on the patient and the strain on the system. So we've got about, I think there's about 8 case studies, and then NHS Supply Chain have got a pipeline of activity that they're going to be working towards over the course of the next 12 months. And what I'm finding is that there's a lot of enthusiasm right the way across the system for a value-based approach, which, as someone who's been promoting it for knocking on for 10 years, it's great to see that it's finally being taken up.
Great. Pav, are you seeing enthusiasm for a value-based approach where you are?
I think so. I think what is that so both these sets of legislation currently aren't enforced. So we still are working to the public contracts regulations, and there's another set from a commission perspective. But I think, like I said earlier, it is quite positive in terms of how we're looking to, I think, see some of that. Just to Brian, see some of the commissioning change in terms of approach and process. So, for example, sometimes you'd have commissioners come out with contracts that they want to renegotiate within a year. And that's obviously not great in terms of making long-term investment and thinking about it's in the best interest of the patients. So, I think from that perspective, it will be really, really positive when we get there. I think it's been a little bit frustrating, kind of seeing how long it's taken for the legislation to come through, and I think we've all been waiting a little bit. But again, understandably, they don't kind of happen overnight, and we've got to get the right the policymakers and people in Parliament have got to kind of make the right decisions. So yes, I'm sure once we kind of get there, it will be really positive for everyone.
That all takes time, doesn't it? But Pav, how can we influence stakeholders across the ICS and indeed further?
I think that probably in the last 2 years, I think the pandemic brought us a lot closer together and got us working a lot more together. So that was, we will talk about the silver lining, and I think that's what that did. And it showed us that we can break down certain bureaucratic barriers and really just kind of just get things done and get things moving. So I think it's around us understanding with the creation of the ICB boards, what are the priorities within each of the ICSs, and then therefore how we want that particular service to be commissioned to support the patients in that particular area. And I think the other thing as well that's been really, really helpful to understand and to help shape it is the understanding of health inequalities, which I probably as much sight of or had the data around. So that's been really helpful.
Just noticing a few questions popping up. Edward, Karen says, I work in local authority and commission NHS providers, GP practices. Will this help LAs procure more easily?
Yeah, really good question. Thank you, Karen. And this has come up quite a lot. Who's in scope of it? I was speaking to someone from a primary care network worried about, saying, well, are we going to have to change the model of care we provide? Are we going to have to be, I was being told we're going to have to be subcontracted through an NHS trust, or they have to pay us rather than going directly through the ICB. So look, in terms of the scope of the two regimes, the procurement bill will affect all areas of public procurement, apart from where there is an opt-out, a carve-out to that regime. One such area will be the provider selection regime, which carves out procurement of all healthcare services. and there will be a definition of that within the guidance. Now that's defined by the nature of the services that are being delivered, not by who's doing the procurement. So that will affect integrated care boards. That will affect local authorities where you're commissioning healthcare services. It will affect NHS trusts or other bodies where they are subcontracting, public sector organisations that are subcontracting healthcare services. So, and yes, the idea is it should make it an easier process. So you don't, you're not obliged to go through a tendering exercise every time. You've got these three options. Number one, you can roll over contracts if you're happy with the nature of the performance of the provider. Number two, you can award it to a uniquely qualified provider. But there is sufficient transparency requirements around that, or you've still got that option of going out to a tender. So yes, it should. I can't really say too much about the procurement bill and about the other areas of procurement that fall under that yet, just until we've seen the regulations that are going to follow.
That was a good question. Thank you to Karen for that. Thanks, Edward, for answering that. Brian, Doug says, where is the value for money component addressed? I have some experience where proposals are closed to rational debate. I raise this as a pilot example where money is not used effectively.
Can you just ask the question again? I'm not really sure.
It's come over. Can you see it on the side? Because Doug's put 3 entries in and I'm not really quite sure I'm making full sense of it. But it says, Doug says, where is the value for money component addressed? I guess that's the...
I think, again, it's quite difficult. I'm just trying to get a sense of what the question's asking. I mean, what we're trying to do with the value for money component, I think what we're trying to do and what we've done with the pilots in NHS supply chain, and again, they're on the website if you want to go on there, it's looking at sort of the impact across the total pathway. So, for example, if you're looking at value for money, it's one of the challenges, if you like, but when it comes to releasing capacity, then you've got a bed day. Now, there is a cost associated with a bed day. And what we're doing is we're looking at bringing in sort of notional values. At the moment, each individual hospital has got a slightly different value for a bed day, but there is a cost associated with it. When it comes to theatre time, there's a cost associated with theatre time. So you take the example I gave before about you reducing theatre time from, I think it's about an hour and a half to 20 minutes. That hour of theatre time, there's a cost associated with it. So that, if you like, in terms of a value assessment, if you like, it allows you to say, okay, I'm going to pay X amount more money for a particular product, but the economic value associated with that is captured in the fact that you've got reduced theatre time, you've got reduced bed capacity. Now, the bed and the theatre will always be there, but what you've got to acknowledge is the fact that, the actual cost per procedure will be significantly lower. So for me, those are the types of, assessments that can be taken.
So you're looking at a bigger picture. And I apologise to Doug if I didn't quite get that across properly. It's all been spread across 3 entries there. So I'm sure Doug will write back if he's got more to say on that. Thank you for that, Brian. But just thinking about when you're talking about value-based procurement adoption, what are the challenges, Brian, that people need to overcome when they're trying to adopt more of a value-based scheme?
I think for me, one of the challenges that we've had in sort of getting the buy-in, if you like, from the procurement community is the fact that it's the targets. So if you're only targeted, if you think about it, procurement is targeted on reducing price. Sellers are targeted on short-term sales. So those two things need to be reconciled. And I think up to now, and I'm pleased to say there's been a lot of work being done around this over the last 12 months, is that, procurement needs to be recognised for generating the efficiency benefits. Because if Pav is in work and she's got a savings target, she's just going to focus on the short-term price. And it's incentivising and recognising the contribution that procurement's making. One thing I quite often say is, procurement as a profession is just kind of normally, it's just how much money have you saved. Whereas if you think about it, should procurement actually be recognised for their contribution to releasing capacity? So, you know, our procurement contributed to releasing 10, 20,000 bed days, which is massive, isn't it? And it can help the wider system benefits. So that's one challenge. The other one is about what is value. So value is a bit like, it's a strange word. It can mean different things to different people. And I think it's very much about ensuring the work that I've been doing with supply chain is to say, okay, look at the pathway, engage with clinicians, identify what needs to change and by how much, and then tell the market that. So I did a pilot about 4 years ago. We had a supplier come in, said, I'm going to save you 2 minutes in theatres, it'll save you £2 million. Now that wasn't a reality. So it's really about specifying for each individual hospital, what does value mean to you? So in that particular case, like save 30 minutes in theatres, I can do something with it. I can list an extra patient. And I think that's one of the other key challenges on it. So it's about recognition and identifying and communicating what value is. I think they're kind of a couple. I mean, I've probably got a list of about 20, but I'll stick with 2 for now.
And do you recognise those 2 challenges, Pav, in your work?
I think just to your point, I think many years ago, I'm really lucky. I've always worked in really good organisations, but yeah, I do think many years. Could you produce a list of projects that's going to save us, you know, £20 on this widget and £50 on this, which equates here? And I think that there is, because of the pressures that we have now, the changing, I suppose, what priorities we have as Trust, as well as ICS and other organisations that are working together. We've changed our approach. So, for example, at NELFT, we have a delivering value group, and that delivering value doesn't just look at cost savings or savings. It now looks at, it has a number of different work streams. So, might look at new ways of working. So it isn't about just focusing procurement resource on a couple of projects that are going to save us money, but it's about making sure that we're inputting into those other work streams. So instead of my IT lead working on the cost saving initiative, they're going to be working with new ways of working to actually spend money and procure some software to help release some of those clinician days so that they can go away and do other stuff. So yes, I do recognise, I think, some of those challenges, but I also think that I can give examples from the other trusts we're working with, the other ICSs, and some of the breadth of the conversation that we have restricted to certain areas where it was tried and tested, like home enteral feeds, buying that as part in population area. Yeah, we are having those conversations across areas that we just weren't doing before. So, yeah.
Pav, have you got any examples of key projects or wins that we can use to really scale value?
Yeah, I think it's a really, really important one. And I think that procurement professionals traditionally have really struggled to engage with digital leads. And because it's all really like, you know, it's like speaking in Greek and Latin sometimes, isn't it, when you're having those conversations. So I think digital as a category is something that, instead of being quite transactional and looking at you know, making sure that things are through frameworks, etc., that we're embedding our procurement teams, our IT procurement leads, within those teams, so that they can really understand what the strategic priorities are and help support. Because a lot of the innovation and a lot of the change that is in patient care is going to be underpinned by digital. Whether it's around how do we procure a really amazing AI solution, how are the procurement professionals going to look perhaps away from a more traditional approach to something else to help them procure what they need to. So making sure that the electronic patient record solutions that we buy, that those are scoped in the right way. We're bringing in best practice from other organisations. I think that's something that we can do really, really well. And I've seen examples of, not just in my trust, but across the system. We sit in the centre of a number of different conversations, and we can reach out to other organisations to understand what they've done well. So sometimes if our network leveraging that, I think that's also really valuable.
Yeah, I think collaboration. We always come back to that word collaboration. Usually it pops up on panel one of any of these conferences. Edward, I feel like you're on the hot seat on Mastermind, but the questions keep popping in for you. Can we try a Jennifer question now on you? Jennifer says, do you think it'll be more or less difficult for the health family to respond to the procurement bill versus other areas of the public sector, and why?
I think it probably will be perhaps a bit more in a way. I think, that part of the rationale of the procurement bill coming through is to kind of standardise and simplify procurement across the public sector. So having a very significant regime and the provider selection regime that carves out sits a little bit awkwardly in that. And I think there's probably some policy wonks out there who don't quite like the idea, because it disrupts that sort of neatness and tidiness. But I think as well locally, for guys on the ground who are kind of implementing it, having to get to grips with these two massive different regimes at the same time is going to be a challenge. And there's one kind of big challenge that I would flag as well. Integrated care boards are being asked to reduce having their running cost allowances cut by 30% over the next 2 years, which is unprecedented. We surveyed ICS leaders, and a clear majority say they're really worried about how this is going to affect the tasks that they're being able to do. ICB is now going through a massive restructuring program. Both, there are merits to doing that after we've come from the CCG era to focus on the missions that ICC systems have got, rather than the world of competition and CCGs. But having to go through that process without any kind of funding as well for change management and front loading it is going to be hugely disruptive. So I do worry about the extent of disruption that's being piled on top of each other and what that's going to mean at a local level.
And while we're kind of on that topic, Edward, just wondering really how all of this has gone down with NHS leaders.
So I think with the provider selection regime, it's fair to say, this has been almost universally welcomed. Whenever we've spoken to our members, the only complaint is, can we get on with it and implement it faster? Because it's going to be welcomed. I think this was expected last summer, then it was pushed back to this summer. I think the latest we're hearing is it will come into effect in January. So it's that it's that time element that's key, but it's really welcome. I think in terms of the procurement bill, I think this is still really a big unknown. We understand that government is looking internally at kind of an impact assessment of what it means on the NHS, but I don't think we've really seen anything in public. I think a lot of attention is focused on the provider selection regime and on the other challenges. We haven't really been able to get into the weeds of what the procurement bill will mean for the NHS specifically yet, so it is a little bit of a worry at the back of my mind.
Cool. I'm now sharing the questions with Brian. Good question there. But Louise has also come up with a good question that hopefully you might be able to answer, Brian. She says, for new systems yet to have a formal procurement pathway, such as FibroScan for early location of liver disease in primary and non-specialist settings, how will these be commissioned?
Go on, sorry, Helen.
I was just saying, is that something you feel you can answer there?
It is a bit challenging for me, to be honest with you, because what they're saying is, I think it's, again, if it's I'm familiar with the product, I've heard of it before, and it's probably worth something taking it offline, I think.
Yeah. Okay. Could anybody else add to that? It's a very specific question there from Louise, but about new systems yet to have a formal procurement pathway, and she's giving the example of FibroScan in liver disease.
Did she mean, is that new, or is that, yeah? I suppose that is what we will see is, because of the number of CCGs having had reduced and then being brought together, I think that what they're going to do is they're going to look at the entire patient population and the requirements, and then look at that commissioning in a centralised way. So just to, I think some of the points that were made earlier, there's 5 key criteria under the provider selection regime, which will be used. So we've got quality, innovation, value, social value, and inequalities. So by addressing those areas, I think what we'll see, probably not immediately, because I think some of this stuff will take time to kind of be put into place once the legislation's been released, but enforced, should I say. But I think once we've seen that, we'll see, I think, a different kind of spec, which is more holistic. Well, how that will be then, I suppose, awarded. Maybe it's going to be sublot still, or one main contractor and subcontracted out. I think it depends entirely on the service.
Brilliant. Thank you for that, Pav. I mean, Brian, I'm sure a lot of people listening to this want to, probably feel inspired by what you've been talking about, adopting, more value-based procurement. And I just wondered, what steps can organisations take to adopt more VBP?
I think really the first stage is very much is going onto the supply chain website and engaging with them. So supply chain, they've invested in looking at value-based procurement. There's been a lot of work done over the last 4 years. So I would say initially, go on, have a look at start small, go on, there's pilots there, go on, have a look at them, see if they're of interest, engage with the local customer relationship managers, and sort of use the experience that supply chain are really getting. We've gone through a phase where we've run the pilots, we've done this thing around action learning, and now we're very much on trying to transition it to BAU. So my advice would be, go onto the supply chain website, get in touch with the local rep if you're interested. It will just give you an entry point to it. It'll give you an idea about what it's all about, and there might be something there you can use fairly quickly as well. So that would be my
Fantastic. I was going to give the final thought to Edward, but he's actually popped off. But also we are out of time. And as always with these conversations, that half hour has flown by. Thank you very much for all being really brilliant guests. So thanks so much to our first panelists, to Edward, Brian and Pav, for starting off the day with an engaging conversation about the reforms in procurement throughout healthcare. We're going to take a very short break now, time to absorb perhaps what we've learnt so far. And if you do have chance, engage with the Speed Networking functionality. Perhaps use what you've learned this morning as an icebreaker. I look forward to seeing you for our next panel on supply chain resilience at 10:40.